and thank you all for joining this session. Let me take an opportunity to introduce the speaker for today's session. Although Dr. Sir does not require any introduction, but as a protocol, he is none other than Dr. Muklesh Gupta Sir. Dr. Muklesh Gupta Sir is a senior physician and a diabetologist at Lucknow. He's a director, diabetologist and physician at Udyan Healthcare Private Limited. Dr. Sir is also a joint secretary, UPR SSDI 2022, secretary Lucknow Diabetes Study Society, secretary Indian Podiatric Society UP chapter. Dr. Sir is rendering services in rural areas of Jagdishpur and Hyderabad for more than 32 years as a social commitment. Dr. Sir has done multiple research publications and participations in clinical trials, 4 chapters. Dr. Sir has been awarded as a Sigma has been got a Six Sigma award by Honorable INB Minister Anwar Thakur Sir, category Best Hospital Diabetes 2022. Dr. Sir is also been awarded with the Diabetes India Award for the Best Contribution in Diabetes Care in Challenging Times 2023 by Honorable Minister Dr. Jiten Singh. Dr. Sir is in charge of Udyan Healthcare Institutional Ethics Committee and Data Industry. Dr. Sir is also known for excellent patient care and service in Lucknow City. So thank you so much for accepting our invite to be a speaker for today's session, sir. The virtual series all use. Thank you, sir.
Thank you so much. And today we are intending to discuss medical nutrition therapy and the lifestyle factors. What is new as far as the 2024 ADA guidelines is concerned? We all know that medical nutrition therapy or nutrition as such plays an important role as far as the management of diabetes is concerned. These are my disclaimers, and we'll be taking the discussion through these topics. Diabetes as a growing concern, as we all know. What is new as far as the management of diabetes is concerned? What is new in the lifestyle, understanding exercise, and the medical nutrition therapy in particular? We'll be also talking about the glycemia targeted specific nutrition, that is GTSN or diabetic specific nutrition. Do we have evidence for that? A recommendation for managing diabetes in different scenarios, and then we'll summarize the talk. But to begin with, we know that diabetes is labeled as the challenge of the century by the International Diabetes Federation, and diabetes is found in every population around the world. It is one of the most common and non-communicable diseases worldwide and has been leading cause of mortality. Data indicates that type 2 diabetes is epidemic in many countries that are economically developing and becoming more industrialized. But if we talk of India in particular, we know that among all ethnic groups, Asian Indians have the highest incidence rate of prediabetes and diabetes. And that roots through various mechanisms and reasons, and they are all intertwined amongst themselves. Whether we talk of the TRPT gene, which drives us towards more of insulin resistance, more of ASCVD in us, whether we talk of more of carbohydrate ingestion, whether we talk of the sedentary lifestyle, what we Indians really are fond of, or whether we talk of various factors which lead to central obesity, and this central obesity then culminates into more of ectopic fat. And now we know that ectopic fat in various sites, more so like in liver, is responsible for driving pre-diabetic population to the diabetes as such. And it is also a contributory factor to MASLD and the metabolic associated disorders, leading to the cardiovascular mortality. So you can understand that we Asians have a lot of factors which are against us as compared to the Caucasian population. If we talk of the prevalence, and if we talk of the ICMR current data, we house nearly 10 crore patients with diabetes in India. At the same time, the point of worry is that equivalent number of patients, they are in the pre-diabetes range or IGT range, and they may gradually convert themselves into overt diabetes. And evidence has suggested that we have seen nearly 10-fold increase in the diabetes cases in the last 4 decades, and this is continually going up. And the data which is projected, we are achieving those projected data even before the projection timelines. Though our counterpart developed countries, they are plateauing, but we in developing countries are still on the rise as far as the diabetes incidence and prevalence is concerned. So, for all these reasons, we have to be more proactive, more alert, and we have to be acting fast so as to really save our population from the menace of diabetes. Now, if we talk of this algorithm, which we see every now and then, I'll simply not go through the details of the algorithm, but I'll try to focus on the first line and the last paragraph. Whatever has happened in between these two, the first line which mentions the healthy lifestyle behaviors, diabetes self-management education and support, that is DSME, social determinants of health, and if we talk of the similar thing which is written in the bottom, whatever has happened in between is the advancement, the change, the guidance, the newer pharmacotherapy, so on and so forth. But the fact remains that in last nearly 2 to 3 decades, the population of diabetes which is under control has not changed. Lot of things have changed as far as the pharmacotherapy of diabetes is concerned. Lot of things has changed as far as the technology in diabetes is concerned. Lot of things probably will change once the AI is also introduced. But really, it has not really converted itself into more number of patients achieving the goal of treatment as far as the diabetes is concerned. That means that there are huge gaps which are responsible for that 70% deficit, which we certainly have to focus on to. So I will not be focusing on to the algorithm in general, but I will be talking about the lifestyle behaviors, which certainly is one of the gaps. Whether we talk of exercise, whether we talk of diet, that is something which is very crucial, and it is always written on the top. And then there is a blue circle, the purple circle on the right, which talks of upscaling the treatment, more contacts with the patients, so that you can titrate, you can intensify, you can modify the treatment so that our patients, they achieve goal. But that is something which is missed. That is one of the gaps. And if we go through the algorithm and finally we reach that the patient is still not on control, once again we talk of the same DSME, once again we talk of the same social factors, once again we talk of the same dietary modifications, whether we use CGMS and try to know that how the patient is responding to whatever he eats, and then we try to modify that so that our patients achieve the goals whatsoever we have set for that particular person. So I'll be talking more about these two factors. That is the lifestyle factors, which are so very important, so very difficult to continue in anyone's life. The physical activity, whether we talk of aerobic, anaerobic, flexibility exercises or the resistance exercises, anything for that matter, is important as far as the diabetes management is concerned. And if we talk of nutrition, then healthy eating nutrition is certainly there. We'll be talking about what is important here. But before that, how a person spends his time as far as 24 hours is concerned, that is something very important. We all spend time. Everyone will have to spend that 24 hours. But then what are the specific components which are important and play a role as far as the management of diabetes is concerned? Talking about sleep, good quality of sleep and good quantity of sleep is really important. A person having good quality of sleep lasting for nearly 8 hours a day is something which is going to be beneficial for the person. And then comes simple walking. And maybe a very minimalistic 5 to 6 minutes brisk intensity walk per day can be equated to nearly 4 years greater life expectancy. But even that is not done by many of us. Ideally, it should be nearly 150 minutes per week of moderate to vigorous activity that is really required for this body to function properly. And then comes the functionality part, the functional exercises. They are required for maintenance of the muscle. We all know that we will be losing muscle beyond the age of 35 years. And that rate is nearly 1% per decade. And beyond nearly 60 years. It is going to be 1.5% per decade. So we all will be losing muscle. And muscle is something which will have to be preserved because that is the determinant of quality of life in the fag end of one's life. But then we miss on that. Likewise, we talk of the chronomedicine. What time we eat, what time we get up. These are all important aspects of our 24 hours behavior. And we know that all these behaviors, they are related to the factors like the glucose production, the insulin sensitivity, the blood pressure, the A1C control, the lipid profile, the physical functions, the psychological part, depression, and overall the quality of life. Whatsoever evidence we have, whether it is in green, that is a strong, or in yellow, that is the medium strength, or maybe unlimited evidence. But still, all these, we all know that it has got impact on all these variables, which are finally responsible for the outcome of that particular individual. And certainly we will have to pay attention towards that. Now, if we talk of the dietary intervention, that is one of the most crucial aspects of the therapeutic strategy. And the aim for this particular thing is that we have to achieve an ideal body weight, or if the person is obese or overweight, a weight reduction that has to be accomplished, that can be done through caloric restriction or by increasing physical activity. At the same time, we'll have to talk about how that can be done, the food choices, the potential addition of meal replacements, and then the therapeutic lifestyle modifications. But ultimately, it is the patient adherence and compliance that is very critical to the outcomes. Because we know that all these, whether we talk of the exercises, whether we talk of dietary modifications, they cannot be short-term measure. You can get short-term advantage, but long-term advantages will not be achieved unless and until a person continues to have that lifestyle modification strategy throughout his life. And this has to be focused because we are really missing on it. The more busy the schedule has become for the youngsters, they are adopting very sedentary lifestyle, spending that 24 hours inappropriately, not sleeping on time, not getting up on time, eating late night, disturbing the total phenomena, not working out. The muscles, they are now becoming weak. They acquire probably more of fat, so convert into sarcopenic obesity or sarcopenia as such, even in youngsters where it should not be there, ultimately affecting the insulin sensitivity. So until whole population is made to understand that this is something which is so very important for your own life, and that has to be continued all throughout. Maybe in the very minimalistic sort of approach, you don't require 2 hours or 1 hour, maybe 15 to 20 minutes, and maybe some understanding about the chronomedicine, maybe some understanding about the food ingredients that is required for everyone. And if that is followed, probably it will make a big change. And once the lifestyle interventions, they are continued, here is the data over 6 years in the China Darking Diabetes Prevention Study. We can see that there is statistically significant difference as far as the outcomes are concerned. In the intervention group where the lifestyle modifications are accepted and continued against the control where it is not accepted. But we know that lifestyle modification, we need even longer studies. And here we see that if you try to compare it with pharmacotherapy, there is an approach that do something in form of medication. Can we achieve the same? Absolutely not. And here we can see that in the DPP trial, lifestyle intervention was almost twofold effective than the metformin in reducing the incidence of diabetes in persons at high risk. That means the pharmacotherapy is not the answer. It is the lifestyle modification which is the answer. That brings me to the topic, proper update from ADA 2024 as far as the medical nutrition is concerned. We all know that the goal of nutrition therapy for people with diabetes is to promote and support healthful eating patterns, emphasizing a variety of nutrient-dense foods in appropriate portion sizes to improve overall health and to achieve and maintain body weight goals, to attain individualized glycemic blood pressure and lipid goals, delay or prevent the complications of diabetes. And then what is the change? Because for pretty long time what we have been doing, once we were discussing nutrition with our patients, what may be to hand over a pre-printed diet chart, or maybe confusing the patient with lot of exchanges, percentages, and maybe imposing certain food substances which may not be acceptable to that individual. And for all those limitations, the limitations exist at the patient's end. The making of the food, it starts from the kitchen. The availability of the help there, the availability of the ingredients, the choices as far as the taste is concerned, the cultural habits, the support system in the house, all these factors, they are responsible. And we, if suppose, are not taking care of all these factors and simply giving out a pre-printed chart or maybe writing some dietary things onto the chart, finally it is not accepted by the patient. He will try to follow it for some period of time, and then finally, more often than not, it will find its way into the dustbin. And this is the ground reality, which now the science has accepted. And therefore, there has been a change of emphasis from nutrients, that is micro and macronutrients. We have to focus on the food and more broadly the dietary patterns of that individual. People eat food, not nutrients and nutrient. So the recommendations have to be applied. The knowledge, the scientific information, that has to be applied to what people eat. So we need to know beforehand. We have to discuss it out. What is the dietary pattern of that person? What he really eats, what he really likes to eat. And after understanding that, we can make some subtle changes, find some important fault, and then correct very subtly maybe a few changes in his dietary pattern, which are the most important ones, so that the acceptability of his pattern continues. At the same time, the correction starts happening. So with whatever information the dietitian has, he or she will have to make only important changes in the same pattern of eating of that particular individual. And this is where the changes occurred. So gradually we'll have to shift that patient from the food what he is eating, rather than putting him and subjecting him to a list of nutrients and maybe becoming judgmental about certain food items. Also, we have to understand that the category of the food, what we define in our literature, they have different health benefits. We know that the whole grains and fruits, they are in the same category as the refined grains, but the health benefits are different. The refined grains are certainly bad. So we have to understand that it's not one sort of size that will fit in all eating pattern. We will have to slightly modify the eating pattern of that individual, taking care of his liking, his cultural, his support system, his kitchen, and various other factors. And then that pattern becomes acceptable to that patient. And this is where this science is changing. This is where the recommendations are changing. So we have to spend a lot of time. Unless and until we spend that time, the person's dietary pattern will not change. The correction will not happen. And then, obviously, the results will not be there. Now, if I summarize the medical nutrition therapy recommendations, and if we talk of the energy balance, for all patients, those who are overweight or obese, we will like that they will lose at least 5% of the weight, because we know that the benefit starts once the patient starts losing 5% of his overweight or obese status. We know that if suppose the person loses 10% or maybe 15%, there are other benefits which also come, and even remission of diabetes is talked about at 15% weight loss. Now, if we talk of the eating pattern, reducing overall carbohydrate intake for individuals with diabetes has demonstrated the most evidence for improving glycemia. And we Indians eat a lot of carbohydrates. So we have to simply add more protein and try to limit the carbohydrate in our diets. So maybe asking the person to decrease from 3 chapatis to 2 chapatis, and maybe if suppose he is hungry, he can eat or add some protein somewhere. Or maybe he'll start trying to eat less, cutting on to the carbohydrate part. That is something which can be easily advocated. Simple one statement to just reduce 1 chapati, maybe at lunch or dinner. That can work as far as the total glycemic load is concerned. If we talk of fiber, then 14 grams of fiber has to go with at least 1000 kilocalories, and that is really required. So we'll have to introduce fiber in some form. So adding salad, green vegetables, dal, whole dal, it's not polished things, the whole grains that will carry fiber with them. So all these things, or maybe soluble fiber in some form, that can be advocated. Fruits, legumes, whole grains, these are non-starchy vegetables. Protein sources of vegetarian protein sources, they have to be added. And a caution about protein, that ingested protein appears to increase insulin response without increasing plasma glucose concentration. So if there is a carbohydrate source which is high in protein, and if the person is having hypoglycemia, that has to be avoided, because in that case, the insulin sensitivity will go up, the insulin secretion will go up, and that will lead to maybe more of hypoglycemia. So that understanding about products have to be there which are rich in protein along with carbohydrate. So these are the cautions which we have to accept. As far as the dietary fat is concerned, then we have to counsel people with diabetes to consider on eating plan emphasizing elements of Mediterranean type of eating pattern. We are all aware that that is one of the most healthy eating pattern which is available. And it is simply more of fruits, more of vegetables, more of salads, and it contains olive, fish, nuts, seeds. So they are all to be incorporated, and they can be gradually inducted into the pattern of eating of that individual. That will not only improve the glucose metabolism, but will also reduce the cardiovascular disease risk of that individual. Coming to micronutrients, dietary supplementation with vitamins, minerals, etc., they are not recommended for glycemic benefit or otherwise. But if you find deficiency, like we see lot of vitamin D deficiency in our type of population, we see more of vitamin B12 deficiency, in that sort of scenario, these supplementations, they are indicated. A word of caution about the beta-carotene supplementation, because there is evidence of harm of certain individuals that it confers no benefit, and therefore we have to be counseling against the use of beta-carotene supplementation. And now non-nutritive sweeteners, because there were a lot of literature in recent times which have been released as far as this category is concerned. So I thought that we should have a word of communication here. So the best thing to do is that have a lot of water, that is to be recommended over nutritive and non-nutritive sweetened beverages, because there is a lot of myth and misconception about 0 calorie and maybe a diet coke and all sort of things. So we have to understand that the best thing to go into the body is water. And if suppose we intend to use not non-nutritive sweeteners as a replacement for sugar sweetened products in moderation, this is acceptable, because it may lead to overall decrease in the consumption of calorie and carbohydrate intake. Now that brings me to what can be done as far as the glycemia targeted specific nutrition is concerned. Do we have good evidence? So what is this diabetes specific nutrition? Because this is basically a wholesome nutritional replacement that will give balanced calories, modified carbohydrate, having fibers on, lot of fiber into it, and that will lead to more of GLP-1 response, better insulin sensitivity, and a decreased prandial rise of glucose. This is what is basically meant by this diabetic specific nutrition. It will handle the nutritional need of that individual. It will also help the muscle prevention, muscle degradation that has to be avoided. So we have to preserve our muscles, so that will take care of that as well. So now how can we use that? So we know that there are benefits as far as better glycemic control is concerned, induction of secretion of GLP-1 is concerned, weight management is concerned, positive impact on the muscle is concerned. So we can replace meal once or twice daily. So we can replace breakfast, we can replace 2 meals, and so that can lead to benefit as far as the control of diabetes is concerned and overall cardiovascular outcomes is concerned. So do we have data for that? Here there is a meta-analysis, 23 studies, 784 patients and various formulas, and what was seen here was to see as outcomes the glycemic status, the lipid status, the medication requirement, and the nutritional status. So what is seen? That it is capable of reducing the prandial glucose to the tune of 18.5 milligrams per deciliter, the peak glucose by 28.5 milligram per deciliter. That will take care of the glycemic variability, which is so very important and independent risk factor. Several studies show that significant reduction in the insulin requirement has happened with the use of the diabetic specific nutrition in our patients. So now if we talk of the glucose and the insulin response and the GLP-1 in patients with diabetes, this is the study which has assessed the impact of 2 breakfast options versus no breakfast, and then study the area under the curve. 32 subjects with type 2 diabetes, and here oatmeal breakfast is used as a matched caloric GTSN. And you can see that the energy balance is matched, the protein is slightly more in the GTSN, carbohydrate is matched, the dietary fiber is slightly lesser in the GTSN, and now we see what happens as a result. So the oatmeal is giving you more of glucose as compared to the GTSN. This is contrary to what we believe and what people believe in their day-to-day life. And you can see the response of GLP-1, which was much more in the GTSN group as compared to the oatmeal. So certainly, if suppose the person is having the diabetic specific nutrition, he is going to have a better glucose control, a better insulin response. So here were the results. The postprandial glucose was significantly reduced by 38% after GTSN compared to the oatmeal. And GLP-1 postprandial was significantly elevated with GTSN as compared to oatmeal. And then the hunger was significantly elevated and fullness significantly lower after the SBF compared with both oatmeal and the GTSN. This is another pilot study evaluating the effects of diabetic-specific nutrition and lifestyle intervention on glycemic control in overweight and obese Asian Indian adults with type 2 diabetes, published in JAPI, that was in December 2019. So the objective was to compare the effect of diabetes-specific nutrition along with diet and physical activity, counseling on HbA1c of overweight or obese type 2 diabetic patients between age group of 30 and 65 on OADs. And we can see that the glycemic variability was significantly affected with the GTSN as compared to the intervention, as compared to the control. So the control is depicted here in the orange line, and the blue one is the intervention arm where we are using diabetic specific nutrition. And you can see that the variability and the MAGE, which is significantly bettered with the use of GTSN. Now coming to the meal replacement in type 2 diabetes, the evidence-based algorithm for the use of diabetic-specific nutrition formulas in pre-diabetes type 1 and type 2. So here we can use the diabetic-specific nutrition formulas in the meal planning of that individual, replacing one or the other meal wherever you find that there is a lot of excursion, that particular meal can be replaced with the diabetic specific nutrition. And then the replacement can be 1 or 2 times in a day, depending upon the requirement of that individual. For underweight patients, there is once again, it is not always for weight loss. For underweight individuals, we can supplement it as a protein supplement for the weight gain as such. So it is basically having both purposes. It can decrease weight in individuals, so those who are obese, where we are replacing high caloric diet with this DSN, or it can be used for gaining weight in individuals, those who are underweight, by substituting good amount of protein and carbohydrate and giving them more calories if they are eating less. Now, if we talk of various landmark studies and the medical nutrition therapy, we talk of this diabetes prevention program that was basically to reduce total fat rather than the calories over healthy eating. And then in the later phase, caloric balance was achieved by restricting calories and fat to achieve at least 1 to 2 pounds of weight loss per week, along with the physical activities, that is 150 minutes per week of moderate physical activity. What were the findings? The findings were the lifetime intervention resulted in 58% reduction in the incidence rate of diabetes. Talk of the Finnish diabetes prevention study, once again dietary intervention study. The carbohydrate 50% of the daily calories, saturated fats 10%, mono and polyunsaturated fats 20%, cholesterol less than 3% was the intervention, dietary fiber was supplemented, physical activity was similar. So what were the findings? Compared with the control group, 3% reduction in the relative risk of developing type 2 diabetes was observed in the intervention group. Look ahead trial, similar sort of findings. So large trials, they have given us that sort of advantage that once you are using medical nutrition therapy in obese pre-diabetes patients, that can lead to prevention of diabetes. So what is the evidence-based dietary recommendation for prevention of diabetes in obese patients? Consume calorie-restricted diet of varying macronutrient content, 40 to 60% carbohydrate, 15 to 30% protein. We know that we Indians consume less of protein, so we have to be decreasing a bit of carbohydrate and adding more of protein. But overall, we have to decrease the total caloric intake, what we really do. And then the fat part, we have to avoid the saturated fat and go in for the polyunsaturated fatty acids. We have to increase dietary fiber intake, which is once again deficient in Indian diet. And then we have to go in for whole pulses. And now we talk of the Shri Anaj and other things. They have to be incorporated in our diet. Proteins coming from the vegetarian sources are better than the non-vegetarian proteins. So remaining vegetarian is something which is very good. And then consuming good amount of green leafy vegetables, fresh fruits, which are allowed and having glycemic index, which is proper, less than 50. That is something which has to be advocated. And then consumption of aerated drinks and refined food has to be avoided, reduced to the minimum, and then include soya and the whey protein in low-caloric diets, snacks or meal replacements. So with these changes, we can certainly achieve a better glycemic control, better outcome in the diabetes. And that is something which is so important because it's a huge gap in our patients of achieving their glycemic goals or achieving overall the cardiovascular goals. So we have to certainly think on these aspects and improve our practice for the betterment of our patients. Thank you so much for your patient listening. Over to the moderator.
Thank you, sir. Thank you so much, sir, for such an insightful session. Now I request the audience, if they have any queries, they can type in the chat box or they can unmute themselves and directly ask the query to Dr. Sir. Sir, hello. Hello.
Yeah, I'm there.
Yeah, so this answer, just want to learn from you that can diabetes be reversed?
if there is a nutrition oral nutrition intervention was there, what other things are required? Because we use to hear from Insta and all this, we जितनी भी updates आ रही है social media, the diabetes can be reversed. So how much
Very interesting area and lot of buzz around this topic of diabetes remission or diabetes reversal. So let us understand what is remission and what is reversal. Now, diabetes as such is a condition which is going to be there for life. This is something which you have to understand. But the point is that we can certainly have a period where the blood glucose levels, they can go back to the normal range. And here, if the blood glucose levels, they remain or go back to the normal range and remain there for nearly 6 months, then we label this person to be having a remission in diabetes. But for reversal, it has to be lifelong. Now, this is something which is not possible. So you will have a remission in diabetes, but you will not have a reversal of diabetes. Reversal of diabetes means then you will never have diabetes in future, which is not possible. So what you can have is a remission in diabetes. That is point number 1. The point number 2 is who is going to have remission. A person with 30 years of diabetes, a lean and thin person with complex issues, is he possible to have remission? The answer is no. A person who is young, maybe who has just had diabetes, maybe 1 year or 2 years or 3 years, less than 5 years. He is obese. He is having a bad lifestyle pattern. This person is possibly, he can have remission once he is adhering to strict lifestyle measures, reduce his body weight, come down to the ideal body weight, and the recommendation is 15% decrease in the body weight if he is obese, and then proper lifestyle and dietary measures, this person can certainly have remission and have his blood sugar values within normal range. So this is remission and this is reversal. What has to be very clearly understood.
Thank you, sir. Sir, since we are talking about medical nutrition therapy, so sir, how macro part of any nutrition or micro part of the nutrition is going to affect in this remission of diabetes? Is there any correlation that this major part should be macro or minor part, or this major part should be this one, micro components?
So our dietary constituents are divided into micro and macronutrients. And the macronutrients are 3: carbohydrate, fat, and protein. And compositely, we have to take it as 100%. And we have to divide this 100 into 3 parts. So if one is decreased, the other will increase, obviously. So we can only have 3 pieces out of this one, you can say a circle, which represents 100% of macronutrients. So if suppose you are thinking of reducing carbohydrate to 30%, then what will you have for other remaining 70%? Something has to be added. So you cannot have a very drastic sort of change. So there are strategies of having very high fat diet and then very low carbohydrate diet, and all those sort of approaches have been tried, tested, understood. But ultimately what works is basically that you have to decrease the carbohydrate, you have to increase the protein, and you have to continue to have that fat, the good one fat, that is the polyunsaturated fatty acids, avoid trans fat to the tune of 20 to 30%. So this is where the ratios, they have to be understood as far as the macronutrients are concerned. Now, if you talk of the micronutrients, they are not having calories in them, but they are required for a lot of metabolic reactions in the body at various places. They are required. And at cellular level, these micronutrients, they are required for even ATP generation. So we talk of an internal hunger. That is something which is because of the micronutrient deficiency. The cells, they are craving for the nutrients, and that is known as the hidden hunger. So one hunger is what you feel and you try to eat. There is another hunger which is felt by the cells, which is known as the hidden hunger, that is more so dependent upon the micronutrients. But actually, if we talk of the reversal part of the diabetes or the remission part of the diabetes, then we are basically focusing on to the overall obesity, because we know that the janani of diabetes is basically the fat cell. The insulin resistance is basically generated through the fat cell. So we have to get rid of that fat part of the body, and that is the inflammatory fat part, which is bad. We have to, because diabetes is an inflammatory disorder. So we have to take care of measures which decrease the inflammation, like yoga and meditation. The calming sort of strategies in body, they decrease the CRP level, they decrease the inflammation in the body, and they are something which will reflect into the inflammation. And then if you have a less inflamed fat in you, that is something which will give you the remission in diabetes. So the quantum of fat has to be reduced, the quality of fat that has to be changed, and then you can talk of remission. And that can happen through the macronutrients majorly, and the micronutrients in the minor way.
Thank you, sir. Thank you so much, sir, for such an insights. So thank you, sir. With your permission, sir, can we send all this and this,
Yeah.
sir?
Okay.
So thank you so much, sir, on behalf of AWHO Nutrition. First of all, accepting our invite to be a speaker of today's session. In future also, we'll be looking you as a guidance and support in imparting knowledge on nutrition. Thank you so much, sir, once again, sir.
Okay.
Thanks.
Thank you so much, sir.
Good night.
Good night.
Thanks.